very, very good clinician, scientist, and a fellow with us. This is a very important experiment which we need to discuss about, because recently we had the IOLs, which had everybody were talking about uh, endotoxins, and one report came as negative, somebody else came as positive. There were multiple confusions about these endotoxins from an IOL. It's one of the most challenging thing is to study the endotoxins. Each person has a different way of looking at it. Most of the time you are taking the fluid from the lens, or and then you test it out. Sometimes you get something, sometimes you don't get something. So during that time, the company did approach us and say that, we really want an answer for this, because we want to change a way of how the production is, whether the problem is with the lens or the fluid. So without actually creating a similar path of what is being done, just taking the fluid and testing, we created a new model of looking at endotoxins. It's just not for this IOL. Let's forget about the IOL. It's done and gone, done and dusted. Now we don't see those stars anymore. But this can be a fantastic model to study a lot of these factors on IOLs and other things. And this is a great model because, and this is again a completely new model. So she was there working during at that point of time, and I told her to just make a small presentation of how you can test endotoxins, because all of you as cataract surgeons should be aware of this. Because one day one company gives you a report, second day some other company gives you a report, and two are not going to match because the way they test is different. That's a background. Dr. Reshma.
Thank you, sir. So I'll just skip the introduction since sir has spoken about this. And so all of us know that TAS is one of the dreaded anti complications for an anterior segment surgeon, and there are multiple reports published in literature. So in the light of the current events, we were thinking if there is a way we could identify and isolate these compounds from the IOLs, which were causing this reaction. So we had a sample size of 12 IOLs, and if you see, they were grouped into implicated, non-implicated, and controls. So what we meant by this was that the implicated IOLs were taken from the same lot of the IOLs in which were implanted in some other patient who had developed a TAS reaction. So these were sterile IOLs which were taken from the same lot. When we mean the non-implicated, these were the IOLs which were taken from a different lot, and the patient did not develop a TAS reaction when a similar IOL was implanted from the same lot. And then we, of course, had the controls. Now, what we did with these, after sterile handling of the IOLs, the fluid along with the IOL was transferred into a 2 ml Eppendorf low binding tube. And this solution was then agitated along with the IOLs for 4 hours at 900 RPM. And then we isolated the solute by a process called as leaching. Now, what is leaching exactly? It's the process, by definition, it means the process of a solute becoming detached or extracted from its carrier substance by the way of a solvent. So when these IOLs along with the solution were agitated, whatever let's say whatever compounds were there within the IOL, they all came out into the solution, and that was what was analyzed. So we ran basically 2 tests for these. So this was the grouping of the IOL. So we had 3 controls, 4 implicated, 4 non-implicated, and a toric IOL, which we used to compare. So we ran basically a sterility test to find out if we could identify any organisms. And these samples were aseptically inoculated into the brain heart infusion broth and then incubated for 37 degrees centigrade for 48 hours. And it did not show any growth after 48 hours of incubation, which meant that the samples were sterile. So we went ahead and we did a endotoxin assay test. So this is the reagent which is used, which is called the LAL, which is the Limulus amoebocyte lysate, which is also known as a bacterial endotoxin testing. And after it was incubated, and this after the addition to the substrate solution, what did we find? So what we found was quite interesting, because if you see the non-implicated and the implicated group, both the group of test tubes show a pink shade, which means that the endotoxins were identified in both these IOLs, we were probably just lucky that the non-implicated samples were the patients who did not develop a reaction. While we did not find anything in the control group and the toric group as well as the blank group. So this was the first step to find out if we found an endotoxin, which was done by the colorimetric analysis. Now, what was important was to find out the concentration of this endotoxin. So the FDA regulation says that the level of endotoxin contamination, which is acceptable, should be 0.5 per ml. And now what we found was that the control group, the implicated one, and the water control samples had a concentration below 0.5, while the non-implicated ones and the implicated between 2 to 4, so 2, 3, and 4, had endotoxin levels beyond 0.5, inferring a high, heavy load of the endotoxin concentration in the samples. We went one step ahead and did a soluble factor analysis in these samples. So whatever was the supernatant, which was identified, we then did a flow cytometry analysis to find out if we could identify any markers in that. So we found a significant elevation of the interleukin-2 when we compared in the implicated group as compared to that in the controls and the non-implicated ones. So to summarize, we investigated the IOLs and the packaging solution, but what is important, as Sir said, was the process was very important, which was called as the leaching, because that was what identified the endotoxins. And we observed the presence of the endotoxin in the non-implicated as well as the implicated group, and the concentration was found to be more than 0.5 per ml.
If you can go back, um, go back. This slide, no, this one. This slide is probably the most important slide for all of us, because minute we see a problem of TAS, we only look at the implicated group, and we think that the non-implicated group is healthy and we forget about it. The question is, it's not that it's completely healthy. The batch, every single batch will have a problem. Only thing that the concentration is not so high for it to cause a thing. So just not trying to just isolate only those batch numbers and take it, because in this case maybe the packaging, it was not a problem with the sterility, it was maybe problem with one of the fluids or whatever, and they changed and everything became normal. So it's very important that many times when you see a report, if you go back to the report, this is never done. Each IOL trying to leaching is never done. What they do is take the fluid out, and in the fluid most of the time everything comes as normal. So leaching as a process is a very big innovation in, especially in TAS. We forget about all this as soon as the story dries off, but minute we get one more. And why it has if you go back to the interleukins part, is the question is, in our own cases we have used this unknowingly, we have used the same type of lenses and the person did not react at all. There was no TAS in them. That's because the body's immune response is so strong, it dampens this completely. And why does it come to only certain set of individual? Is because his response in the body is not so strong to dampen it. So your individual response also has a huge role in this. So this is the take home point from this, and there are different ways of actually looking at measuring the toxicity of anything, whether it's IOL, tomorrow contact lenses, or anything. Any question, Ashish?
Very closely follow these biosimilars.
Yeah.
So biosimilar example, I will tell you what happened in, if you remember, India is the first country. We are the, probably, we lead the world in biosimilar, because was the first country when first biosimilar ranibizumab was launched in 2015. But I'm not sure how many are, here retina specialists, but you must be remembering around 2015-16, they had some inflammation with few batches. All right. Now, after that, there's no inflammation. We have now 2 more molecules, no inflammation. So the story goes behind that what happened in 2015, we were following this endotoxin limit, which was defined by ISO. And ISO limit was 0.5 EU per ml. But over the time, what happened, retina and anterior segment, they are kind of a different chamber, and the endotoxin affects in a different way. FDA was not differentiating it. But in 2016, FDA realized that even if you titrate less than 0.5 EU, is still in retina, you might find some inflammation in some of the cases. So then there was another advisory from the FDA, it came into play, and now the tight limit is 0.3 EU per ml. So 0.3 EU per ml, since it has come, now there is no biosimilar which is causing any kind of inflammation. So even if you look at Lucentis, when the first trial in 2006 was, the inflammation rate was 0.17. So over that time, this FDA guidance and this improves. So it means endotoxin in this particular sense, I would say, even Rohit, if you can work with the industry, tell them, because now these lupin and our intas, they maintain endotoxin limit in these anti-VEGFs approximately 0.08, which is much, much tighter. So if they can put it much tighter limits, then, things would be in a great shape.
And you know what? More than one is the endotoxin level of your thing. If this person's one of these molecules is already higher, even before you gave an injection, and you inject something which has an endotoxin, you will do a double whammy effect there. And
True, that's what brolucizumab is doing.
Absolutely. Thank you, Reshma, and wonderful. Anybody has a questions for her? Thank you. Yeah, we have a question.
There is something like intraocular lens. They have this endotoxin level, but the same is for the medical devices also. So we have only one endotoxin level for the intraocular devices. But actually, the hydrophilic lenses, hydrophobic lenses, all they have a different properties, and that kind of EU has not been defined at anywhere. So this thing has to be taken care of.
Yeah,
So
that's one of the reasons. What we did was we used hydrophilic. We used the hydrophilics, no control of only hydrophilics, and the U content of hydrophobic. We used the so every lens had a different control. We never used one control for everybody. That's one of the reasons. Thank you. Yeah, Edwin.
Brain heart infusion.
Yes, it's mainly for the anaerobes and fastidious organs.
So you can get all the touches.
Yes.
Thank you.